All right. Good afternoon, everybody. So my name is Sudhakar Mohan Raj. I'm Chief Technology Officer for Access Unify Health. And we are here gathered today for the Customer Advisory Board meeting at Access Unified Health. This is happening in person in Los Angeles, California, February 21st. And we are having a panel discussion. The SCAB is a full day event. One of the agenda items in the event is this panel discussion, which is getting started right now. We're doing a live telecast of this as well. Uh, so the topic for the panel discussion is from data chaos to data control. What's failing, what's emerging, and what will win. So to start with, I will allow the panel members to self-introduce themselves briefly. I'll be the moderator of the session, so I'll be mostly asking questions, and then the panel will be giving the answer. So we'll start with the self-introduction on Robbins, starting with children.
Okay. Well, I am very pleased to be here today with having the chance to be able to speak among all my colleagues and being part of this. But my name is Tulu Can Kurtaran, and I am with Novant Health from North Carolina. And I've been in the data business for the last 25 years. I'm the manager for the database team, data archival team, and data conversion team.
Brian Sturd, Chief Information Officer, also Chief Information Security Officer for Faith Regional Health Services, located in Northeast Nebraska.
And Ben Cassidy, Director of Research and Strategy for Class Research. I cover value-based care, archiving, small piece of AI, and some of the interoperability spaces.
I'm Sue Morrow, Chief Information Officer at Episcopal Senior Life in Rochester, New York.
Hello, I'm Brandon Camp, Vice President of Delivery at Health Data Movers. Amongst all the things we do in healthcare IT consultancy, a big part of our work is data migration. So we're able to collaborate a lot with Access here.
David Hazeltine, Chief Medical Informatics Officer at Thailand's Health, and we've used both HDM and Triumph in terms of migrating about 6 different EMRs over to their product in the past 2 years.
Ben Bloom, Director of IT, the New Jewish Home, New York. In a sense, continuum care, but skilled nursing facility. That's about it.
Thank you. So first of all, thank you for being a member of Access CAB, and thank you for being present today in person. We appreciate it a lot. So talking about this topic, if there is one thing we are all agree on today for healthcare is there is no lack of data. There is in fact a deluge of data. There's a lot of data to manage and control. So we're going to spend the next few minutes discussing about how to control this data. And this data comes from various digital sources. Of course, the electronic health record, then we have the imaging system, then we have the archival system. Then we also have various other systems like the health information exchanges, data warehousing, and so on. So where is this data all coming from? Can we trust all this data? And who's actually using this data both clinically, operationally, and how useful is this data overall? We'll also explore what are the trends which are happening in the industry in terms of managing this data, what is really working, what is not working and failing, and most importantly, what we think as a panel is going to work this year, like the end of 2026, what do you expect to see as happening in this data management space? So the way the panel discussion is going to happen is I'll ask one question and then the panel members can participate and give the answers in about 60 seconds or 2 minutes. And other panel members are welcome to join the conversation and add on to what one member answers. If you'd like to pass a question, you can pass the question. So our objective is to go deeper into one area rather than try to cover all the questions. So feel free to spend as much time as you want on any particular question. So with that, if there are no questions to me, I will get started with a warm-up question. It's opening question, just setting a context. So when you think about healthcare organizations today, do you feel the health systems and other vendor organizations have good control over the data, or are they just still managing around the data? What does data chaos mean in your world? Do you have real life examples of some real data chaos happening in your work environment?
I'll jump in. I would say, and this may not be exactly where you were thinking the answer was going to go, but I will tell you, there's in terms of data chaos, we find there's data scattered everywhere, and so all it takes is a good data loss prevention project to determine or understand how many places on your network that you have data that you maybe didn't realize it. So as that relates to archiving, obviously, if that data has been archived, then maybe there's no need to keep it, or you could potentially discard it. But there's pretty with my cybersecurity hat on, there's a lot of risk for places where data is used as a staging mechanism or is used temporarily and then not properly cleaned up afterwards. So I would say that's probably where a lot of my concerns are. To the extent that we can make sure that they've been archived and then remove those, that's what we would love to do.
So I'm not obviously a clinician, not a healthcare organization. I do, however, speak to a lot of organizations, and the term swivel chair comes up a lot. These poor clinicians in their day-to-day lives, they are in many cases trying to keep the lights on. They're trying to take care of the health and well-being of you and I. And when they've got multiple sources of data, disparate EMRs, there's data chaos. The data is everywhere. It lives in different systems of record, and you're talking thousands of clicks and interfaces, and sometimes finding the correct birth date for a patient in their history can become a very cumbersome task. So just the disparate sources of data is what we hear a lot.
I'll go next. In my world, and I'll start with just a lot of database and data conversion. I've just recently been in the data conversion world, and we had to extract data out of source systems or source different EHRs. That was challenging because they didn't know where their data was, let alone just extract it efficiently and give it back to us so that we can put it in our EHR system. But then, other than the EHR system, you have other EHR adjacent applications where you want to combine that data with your EHR data, but there's different applications coming into my organization, and nobody knows who owns them, who are the business owners, what is this data, what is the purpose of the data, how is the security going to be handled around the new data that's coming in. I mean, there was a lot of chaos, and it definitely made it hard to be able to categorize what's coming into your organization and what's not, and what's exiting your organization, because and do you have duplicates now? You have multiple applications coming in. It's definitely have been hard, and my organization have made a lot of advances over the last 10 years, but still we are lacking security and governance around our data, which we're working hard, but maybe one day.
Well, I can add that the main issue I see is between cost effectiveness and user culture. You'd have leaders that will tell their staff, use an Excel spreadsheet, even though there's an information system. You'd have people tell us, why don't you invest in more of a robust system? Well, we don't have the funds. So you can set it up between the technical, operational, and cultural thing, which creates this multitude of data coming in without the ability to say, stop, we'll invest in one single pane of data, because it just doesn't happen. And try and convince a leader that his Excel spreadsheet method is wrong. You know what they do? They hide it from you. I've seen it. They put it under a drawer, and then they use it when you leave, and they like take out from the drawer and they check mark on their printouts, and you're like, and in a sense, it affects everyone. It's not just the frontline people who have to deal with the day-to-day basis of the mishigas between the Excel spreadsheets and the systems, and where do I document it, and why do I do it twice or 3 times or 4 times. And then the leadership, when they come and ask for succinct reporting, they have all sorts of questions on why can't you calculate 1, 2, and 3? And you have to say to them that the Excel spreadsheets do not have any connection to the incoming data that was collected because nobody bothered to put a unique ID. So how do we marry this data together? Does anybody have enough time in the day or in the month or in the year to make it so? So everybody's affected by it. You try and put stringent rules, and they all try and find ways around it.
I would agree. I think, just speaking from a clinician's perspective, we didn't train people really well starting out in order to how to put things into the EMR, and then people also found ways around that. So when it wasn't easy to use, they found someplace else where it was easier to use. So as a result, we have a number of data that's not standardized at all. That's not normatized across different EMRs. We tried to bring all 6, and you could find different areas based on which your different clinicians had. So not only did we have 6 EMRs, but we had hundreds of different ways of putting data in, depending on which clinician used that EMR in a non-standard way. So the chaos is only as good as the person that's there, and you have probably multiple ways of doing the same sort of thing.
I think I'm going to add to this from a perspective of actual like program management, program discipline. So from what I see in the work we're doing, right? A lot of times they're not thinking about the data migration and the archival till later, right? They're being reactive about it. Like why this should all be considered at the time you are deciding on this new HR and when you're gonna implement and roll it out. And what we find is we're engaged too late. Timelines are compressed. You don't have time to get proper validation of the data, which in turn builds confidence in your users. So it's just a domino effect.
I think, 10 to 15 years ago, when everyone was beginning to implement an EHR, we were coming from paper. So there was really there wasn't a need for an archive. It just, everything got boxed up and packed away. Now that a lot of organizations are going from EMR to EMR, we're creating now this need. So Access Unify Health has really filled a big and necessary gap there to house that data. We've got applications, whether it's in an EHR or I call them tentacles. There's other applications, dietary on the long-term care side. We have several other things that we've run historically, dietary systems, rehab systems, recreational therapy, those sorts of things. And the data can be in multiple different systems. It might be on an old server that now presents a security risk. A specific example, we had a rehab application that was originally integrated with our previous EHR, but only funneled in the required data for billing, not all of the detail of the physical therapy or OT that they were working on. And then that was purchased by another company, so we had to download that data. Then where do we put it? Do we just stick it on a server somewhere? How do we manage that? Is anybody ever really going to need it? Do they need to find it? What does it look like? Is it even accessible? Is there a user interface for it? So it leaves us, really figuring out where do we keep it, and this application really gives us a place to store it and bring all those things together. So after creating our archive of our former EHR, now it's got me thinking about what other things can we put in there to really bring all these pieces together.
So I heard a lot of comment on data called multiple systems, and then so the next some files. This is the unstaged very quick and budget operations and household changes and how people operate, and also planning, right? Sort of how well ahead of time the plan, the better. Those are great things. In fact, that's already touches upon the next question they have. Is that truly a single source of truth? Is that a real thing or a myth? Probably found, as you already touched on. So everybody talks about a single source of truth for healthcare data. In reality, there's such a thing really exists in any organization today, and if not, one is standing in the pain. When EHRs were implemented, many people thought I was on, all their problems, but it is truly the case is that the single source of truth.
So you'd wish. The basic problem here is leadership. It all stems from up top. If the CEO comes down and tells the organization, see this software, you all use it. If you don't use it, you get fired. That's what I wanted to do. Use it or get fired. Now, if he does that, they all use the same software, you get what you're talking about a single place where it's true. But the moment the leadership, how do I say this? They just lose focus. Oh, why don't we bring this? It's better. It reduces productivity. Let's put that in. Let's put that in. Is it interfacing? Does anybody care? They bring it all in, and then they expect to get all this reporting from a data warehousing perspective and have a single pane of everything in the same location, and they don't get it because they lose focus of what they really need. So if you move quirky around, don't expect to have a single source of truth. It'll never happen.
Yeah, so I do wonder whether you can have one single source of truth. I think we all know the moral of that small story about the blind men who are all looking at an elephant, right? So, and the problem is massive amounts of healthcare data are this huge elephant. Well, you have different people looking at different parts of the data. You have people who are going to different institutions over different periods of time. So over the course of a lifetime, you may touch multiple institutions, multiple EMRs, multiple areas, but people are only looking at small subsets of the data. So everybody's individual source of truth depends on what point they're looking at. There is no one individual place that looks at the entirety of the unity of information on any single given patient.
I think no is the answer. There is not. But I can give an example in terms of a discrepancy between our EHR and the CRM that our marketing department uses. So, our EHR will have a certain number for a daily census, and the CRM will show something different. But even though the CRM company themselves says your EHR is the source of truth, but the marketing people don't believe that. So there's always this discrepancy each day in terms of what the census looks like. And sometimes it's because there's an anticipated move out that's been recorded one way or the other at different times. So it's confusing. And then people, of course, don't trust the data. As Ben mentioned, there's always workarounds with whatever clinical user, nursing, whoever, be making spreadsheets, putting things in things that are more comfortable for them to use instead of using that source application that should really be the source of truth. But if it's not looking like they want it to look, or it changes, or it's too complicated for them to put the data in, then they find workarounds and they make their spreadsheets and they hide them. Yes. I also think sometimes regulations don't help. HIPAA is great. We've got policies around that, but they don't necessarily give us the true guidance in terms of operationally how it should look. We make a policy And that's in theory what we should be doing, but it doesn't always align with what's actually happening. Anything else?
And I agree with most of the comments. I mean, I don't think there is any one source of truth anymore. And also one source of truth for what? It depends on the perspective. It depends on context. If you're talking about clinical data, yeah, maybe EHR should be your one source of truth, but a lot of times it's not. There's other applications that you have to combine that data with. And then, or are we talking about financial data? Are we talking about HR data? I mean, some of that, especially when you get into clinic informatics and analytics and reporting, you have to pull in from all different systems, different data comes in. So there is really no more one source of truth. And there's different domains of data. So you have to master all those domains of data and put it all together in a meaningful way so you can report out. But again, who's the user? Who's the customer? Who's the audience, for that data? That's important.
So that's interesting. Is many people who are outside of healthcare generally tend to think that there's one part that you get that one seeing total totality is there. Maybe that's a fair thing to assume, but in reality, these are very different. So that takes me to the next question, which is about clinical adoption. Even when there is some data available, what data really gets used in the clinical setup? So when it is available, clinicians and researchers don't always use it. From experience, what breaks clinical adoption of data the most? Is it because of lack of trust on the data? Is it because of lack of access? Is it because of the workflow? Or is it something else? Like what is preventing the clinical adoption of data?
So from my perspective, it's all of the above. I've seen a lack of adoption take a lot of different forms, but one thing that wasn't mentioned is actually time. On top of all those other things, that they're clinicians we've established they're strapped for time, and adoption of not just an archiving technology, but all of their technologies, that does tend to take the back burner. Training is often an area that gets neglected, but I'm not just talking training. I'm talking deep, true adoption. Most organizations will take that initial step and do that initial training. But at our tabletop earlier, I jokingly referred to this adoption concept as setting a plate of broccoli in front of a young child and saying, this is going to be really good for you, and so you need to eat it, and then walking away. And the reality is that children are not going to eat a plate of broccoli by themselves. And in the same concept, clinicians are busy. They're again strapped for time. So even if they know it's good for them, are they going to ultimately eat their vegetables? And I love this concept that training generally happens. Training to adoption cannot happen by chance, and it can't be left up to chance. It has to be very deliberate. It has to be driven. And at the end of the day, the clinicians need to understand the why behind the adoption. How does this impact my life? Not just how is this ultimately going to affect the documentation, or you mentioned that they create these workarounds. If they don't understand what is in it for them, what their life looks like, they're not even going to be coerced to train and adopt.
Any real life examples anyone would like to add?
I think my opinion is it's workflows. When I went through an EHR conversion last year, there was a strong sense from especially the nursing team that they wanted to adopt their workflows, or not necessarily enhance the benefits that this new application had for them, but to make their workflows work in the new EHR. And when they are being trained by the trainers from the EHR company on how the system works, how it's supposed to work, and why this might be better for you, I had several examples of nurses saying, no, let me show you how we do it, and you make it do it this way for us. And that's just not the way it's built. So it's a training piece, and then the inability or the not wanting to change the way they do things to truly operationalize to their benefit, and not recognizing that possibility.
I think just to add to that really quickly, right? Sometimes healthcare systems are enabling them as well, right? Are they retiring the legacy systems or keeping it on just so these clinicians have access to it, right? So then they never learn how to do it or the way it should be done, or maybe think of coming up with a workflow that it can be done in the new system.
And I think it's not that people don't want to do these things, or they don't want to eat their broccoli necessarily as well, but they want to. They have a desire to do these things, but they want to do what's best for the patient, but it's not necessarily the easiest thing in the world to do. And they like those workflows because they know them. They're easy. They're well ingrained. They're able to use them without difficulty. They want things, and we'll use things that are easy, but the new softwares that we have are different. They're not well trained on it. They don't understand how to use it. It's not easy to use. It's not intuitive. People will pull up and use anything that serves them, has benefit to them, and is easy to use. These new software things are not always the easiest of things to use.
I would couple comments. One, I would underscore the biggest, in the 20 some years I've been in this sort of world, the biggest issue or failed implementation is exactly what you mentioned in terms of, let me make this new software do it the way that I wanted to do it before. There has to be some balance of, yes, there's certain things that do need to be done, but they should be done within the confines of the way the software was designed to work. And so I totally agree with that. I feel like you really hit that on the head. Second comment I'll have is a real world example, and I don't know that this is altogether a bad thing. So in our circumstance, the legacy EMR we were coming from was contracted for some period of time after we went live. So back to Doctor's comment, it's once we were live on our new EMR, but that old EMR wasn't yet sunset. That's what I know how to use. Why wouldn't I use it? I don't think that's a horrible thing. Go use that. You don't have to reteach yourself. So in our circumstance, it could have just been circumstantial in the fact that we archived later because we were contracted for so long on our legacy EMR. It didn't make sense to archive too early. We were going to pay for it either way. So I'm not sure I would go back and change that. And probably, and Doctor also mentioned earlier today that as time moves on, the relevance of the clinician to go back to that data is diminished. So I don't know that it's altogether a bad thing that when they needed it and when it was timely, they could go to a system they knew. And now as that has sort of waned, they just don't need it. And the new product is not something they're going back to as often. But again, that's just for us, that was a contractual thing. And you could, I guess, make the argument we sort of just got lucky because that's how it went. But I don't know that it was altogether wrong. I think clinicians need to do what they need to do in the fastest way that they can do it.
I would equate this to a political campaign. You have candidates. It's all about how you sell it, how you plan it, how you market it, and your choices. And I've seen campaigns for millions of dollars worth of systems fail because the incorrect start point was decided on, or it was not scheduled correctly with the sunsetting of a different system. And it's much more complicated and requires much more strategy than we think. Yes, the users like to cut corners. They want it to be quick, easy. All of the above is correct, but it's all about the planning, the forecasting, using the right people inside this project. You have to choose your people who would drive this project forward, and you have to select correctly. And there's so many mistakes to make in these projects. They're immense. So when you make the right decisions and you do everything right, maybe the candidate sucks. I'm sorry to say. It's a bad product, and somebody upstairs decided that you have to implement it. So at first they'll be like it'll be stuck in their throat, and maybe they'll just eck on and move on with it, or they'll chew it out and just spit it out. But the users are not to blame for what we feed them. They are part of a machine that works in order to provide productivity. It's about how you sell it, how you market it, how you embed it in. And it's on us to make it work. The implementors have to know their business. I can't just come to them and say, here, use it. Why are you not using it? Didn't I provide you enough cheat sheets and guides? And didn't I provide you enough testimonials on how great this is? They don't care about that. It's about how much training I put in. It's about how much time I gave them to work on it, whether I decided to put on more overtime so that they have more time to ingest it. As you mentioned, the working with the sunset system. And did I set an innate? Oh shit, I cannot use this anymore. I have to use the new system. So it's much more complicated. It's an art. You have to know what you're doing. And if you mess up because you didn't invest enough time in the implementation team or the design or anything else, you have no one to blame aside from yourself.
Those are all great points. So we talk about lack of time, training, integration with workflows, and also the commitment of the top management and the planning needed for implementation. So these are all play a major factor in deciding, how the clinicians ultimately adopt systems. So moving on to the next topic, there are always things which we know and which we do not know, especially in data archiving. So one phrase we use often is know the unknowns. Many organizations assume data retained in legacy systems they remain safe, complete, and retrievable all the time till the end of time. But that's not always true. So what is your experience has been like this perception of retaining legacy data in legacy systems, and what people think about it when it comes to implementing archival solutions?
I'll go first real quick. I will touch on the retaining the data in the legacy systems, but first, as far as knowing the unknowns, we need to make sure that we have subject matter experts, for example, in the archival world, that will be us, making sure that we're advertising what we know to the rest of the organization so that they know what archival means, because we all know it, but an executive out there may not know it. A doctor out there may not know it, or an engineer out there may not know exactly what it is and what it means. So we need to evangelize. We need to advertise what we know, because otherwise you're gonna have to compete with assumptions. Everybody's gonna assume something. Oh yeah, archival. We saved the backup of the database. Oh, it's there. We archived it. Oh no, archival. We have the legacy application still there and functional, which they don't realize that server maybe no longer even operates because it's a 2003 server, or it has so many cyber risks, security risks. Oh yeah, we use so and so system to archive the data. Well, you may have 3 different archival systems sometimes in an organization that nobody really knows about which one to go to for which kind of data. So a lot of people make assumptions. So that's why we need to step in early in the process of whatever is being done for archive data, and show them the way. But it is as far as assuming the retained data in legacy systems is safe and complete and retrievable. It really is not. Like I said, there's a lot of times when these things are on-prem on old servers where they're not reliable anymore. You can't access it. People, the SMEs are not there anymore. They're no longer with your organization. They don't know how to use it. Nobody knows how to even, sometimes you don't even have the password to log into the system anymore. But it is definitely not safe, unfortunately.
I would say it's about planning and policy. In a sense, we have a structure. We have, in our team, we have what is called primary and backup. I have a primary SME and I have a backup SME, and they know what they know, and we have a running list of all the applications that are active, the legacy, the back, whatever. And we run quarterly updates on that file. Like, we update everything. Like, is it still available? Who entered last? What's your role there? You admin or you admin? Again, we work based on policies, and we document. And if you do these 2 things, and somebody calls up and says, what about system so-and-so? You go into your file and you can locate who last accessed when and why and et cetera. You have that capability within you. It's just about keeping up with it. And the expectation is for the organization, they come to us, we're the ones responsible for the access, we're the ones responsible for who was there last and what are we doing with it. I don't need a specific clinician to call me and say, oh, I used to use something and now I don't remember how to access it. I'm not asking them to do that. That's on us. That's on me. And I need to put the people there. And if somebody retires or somebody decides that he doesn't want to do it anymore, I don't know, whatever, I find a different person who will then assume that spot. And when the system is retired or we sunset it or whatever, there is a new protocol, we put it in that protocol. And just a month ago, I had my CFO call me about a system that we sunset 2 years ago. I knew all about it. He just had to ask, and I had to tell him, we kept one backup. You need us to revive the backup. I need a quote. With using the quote, we'll revive it, whatever. But still, everything was documented. Everything was in the know. It's all about adhering to policies, in my opinion.
Good. Thank you. So moving to the next question, it is industry trends in data management. The healthcare industry in the data space has seen a lot of trends. So initially it was the EHR implementation, then the interfaces, HL7 and on the FHIR, then the health information exchanges, then we had the TEFCA, and now we have a lot of systems moving to the cloud. So a lot of things happening in data management. What trends do you see are happening now, and what do you think are real, and what are just hype?
Well, two things. You have data warehouse. I think that's a real thing. I think that's here to stay with regard to the collection of the data within the organization and the presentation of it for the entire system. So I don't think that's going away, but I do think AI is going to affect this in all sorts of ways that we haven't yet to even started to understand. The other thing, you mentioned cloud. I think cloud computing is going to be major with regards to anything that we do, from access management to software management to our cybersecurity. It's going to be all encompassing when it comes to moving away from the organization. And my guess is that in 5-10 years, everything is going to go back into the organization. So that movement of back and forth. But for now, it seems like a real thing. The competition is going to make it cheaper. You're going to have storage for less. It's going to go down and down and down and down until it reaches a certain point where there's going to be, resource shortage. And then it's going to go back into the organization. We'll have to wait and see, I guess.
I'm most excited about synthesis and presentation of the data. I think we're now getting to the point to where we have wide enough spread cloud-based computing that it can go through, mine the chart for different actionable items and present it on demand in a context that is most useful to the provider at the point that they need it. And so they're not waiting for somebody to go back and look at the data. They're not waiting for somebody to go back and retrieve. They're not having to wade through it themselves to be able to find it. The computing power is now there to be able to present it to them, actionable information at the time of point of care.
Yeah, I agree. I think the data that we have now is going to be able to give us the dashboards that everybody's talked about for years and using Power BI and things like that, which wasn't always practical because you couldn't get meaningful data out of these systems. Now with the AI tools that we have available and other data mining capabilities, we can bring that into really useful metrics and information that you can use operationally in your organizations. The other thing I think in terms of interoperability is that long-term care has sort of lagged behind the hospital EHRs and the provider-based EHRs, and I think that should change. I think we need to start focusing more on keeping our post-acute systems more in line with the HIEs and the interoperability to make the data that we need in these long-term care organizations more effective.
and I'm going to jump back on the AI bandwagon because I think it fits in both the, what is some real trends, but also the hype. It's lived in hype so long. I'll bet any one of us, if we walk around at Vive this week, we're maybe 5 booths that don't say we do AI. That's just become table stakes to say we do AI. But on the other side of that, we field questions and have been fielding questions for the last several years, and we get calls all the time with individuals saying, my CFO just told me that I have money to spend, and they told me I have to use AI. What should I get? What should I buy? And well, wait a minute. First, figure out what problem you need to solve. Then ask yourself, do I need AI to solve this? Because AI is expensive. So there has been this very real hype around AI. That said, it does feel like we're finally starting to move beyond the hype cycle of AI, and I say just barely. We're finally starting to see things start to leave pilot purgatory a little bit. The obvious areas, the ambient listening, wildly out of control, blown up, imaging, but we're starting to see pockets of real success, and we're starting to hear providers ask the right questions, not what are the capabilities, what are the features and functions, but what are the outcomes. What am I going to achieve using AI? And so it feels like we're starting to get into the more real, the more real benefits of AI moving forward, and it's coming, whether we want it to or not. It's coming.
Yeah, those are great points. In fact, you guys already answered my part of my next question about AI. But let me ask the follow on about AI. So you talked about the benefits of using AI in summarization and synthesization and so on. So there is a real question of ROI, whether there's a return on investment on some of the AI projects. And but my question is related to the risk of using more AI. Do you see or anticipate any risks of using AI, and how can we mitigate any such risks?
I will say, first, a couple different types of risk. The first one is, as was just mentioned, if you're looking for a solution, if your solution looking for a problem, that's a huge risk with AI. There, I'd love to have the CFO, by the way, that says, "Hey, I have money for you to spend." That'd be great. But I mean, so we've really taken it may sound simple, but a problem-based approach to it. What problems do we have, and what solutions can we bring to bear to solve those problems? And that sounds simple, but as you just mentioned, there's lots of people doing that backwards right now. That's risk. I think the other, maybe more what you're talking about in terms of risk, is that there has to be. This is one of the few times in my career I'll ever ask for regulation. I think there has to be more and better regulation with AI because of the risks that are involved. So how can you justify decision making, particularly with patient care? What if it's used based on AI and there was an issue with it? What's the accountability? How does that need to be justified in terms of, the data science that goes into those decisions that are made? So there's in my opinion, a ton of risk. I think some of the first places to look towards are things that aren't related to patient care, and that can reduce that risk also. And then if it has anything to do with patient care, I think then there has to be a human in the loop, at least for the foreseeable future, so that there's somebody who can be held accountable for what those decisions are. So I think there's a lot of risk, and frankly, all the organizations that are purporting to do AI right now, not all of them are going to pay the bills. So it remains to be seen who's left standing and who actually is going to advance the industry.
I agree with the regulation changes. I think that we might need some changes to HIPAA requirements in terms of our business associate agreements. Companies, even though they're running some sort of private AI platform, they're still using the large language models. So they can't sign a BAA because they're using someone else's LLM. So it's putting us in there's a risk there in terms of our HIPAA requirements and compliance.
Absolutely, I agree. I was just gonna touch, very near that. I mean, we're talking about, the CFO comes out there, all right, I got money, and somebody's gonna jump on that because they want to look good to the CFO. They want to jump onto that next shiny tool, so they're gonna start building their AI tools, not realizing possibly exposing the patient data to public, whatever the channels are within that AI tool. If they don't architect it right, if they don't use the governance and the human person in there in the loop, and if they don't have some kind of a steering committee or something, advising committee, the data is not going to be secure. It's going to be exposed, and somebody's going to pay the bill. And it's not going to be that CFO.
Yes, it's like taking the kids to the Luna Park. They want to go on all the rides. They look really shiny. Everybody from their own perspective, right? Leadership looks at increased productivity, less staff that's needed, and maybe saving some money because we are now implementing a bot instead of a person. And it's all, I'm sorry to say, BS. The children, so to speak, the clinicians, the users, they're like, oh my God, there are new tools. All everybody's talking about, and their eyes are like shining bright, but they don't realize what they're talking about. So there is, the police, the IT police, come down and say, guys, we cannot just implement anything here. These tools are scary. You can implement a tool that will fix your grammar, but it reads everything that you write, places it somewhere in, I don't know, East Europe, and somebody's reading all this stuff, collecting it, and making something else out of it. So it has to be HIPAA compliant, and it has to adhere to our policy, which we actually wrote. We didn't ask an AI to write it, which is a really good thing. And we made sure that our users understand why we're walking the straight and narrow. This is unproven territory for us. So first we have to see that it actually provides anything tangible that we can work with, and then we proceed. Now, we constantly told our organization, IT doesn't want to be at the forefront. We're not the leaders of this. We're just, again, submitting the policy, telling people whether it's compliant or not. You, the leaders, need to come down to us and say, I want this tool. This wound care tool is a game changer. The users are going to use a camera, they're going to take a picture, and the AI tool is going to look at it and it's going to tell them instantly whether there's improvement or not, and what type this is, and whether the conditions have changed, whatever. Do the users really want to use this tool? Are they really willing to walk around with this handheld and take the picture? Maybe they just want a piece of paper and fill out the blanks. It all comes down to leadership. You want something, we'll check if it adheres to the policy, and then we'll implement and see if the users really want to use it. It's like any other piece of software. Calling it AI, in a sense, is a little bit of a mockery. It's new applications, and we implement them all the time. The fact that they're called AI is just a hype.
And I'll just add, it's always been true that bad data in, bad data out. Where this changes is it's at lightning speed, and with the hallucinations that are possible, and the all of the security concerns. Another piece of this is the human element, because it's still very present. And so I would say that the education piece is a very real risk, because if you have individuals that are using the technology that have not been properly educated, not just about the how, but about the things that could possibly be catastrophic.
Think of them abusing the technology.
Yes, it could get really bad really quick. And again, this turns into the adoption equation a little bit, because the reality is they don't want to take the time to be educated about it. And that actually creates some reticence to adopt, because they don't understand it. So it's kind of a double-edged sword. Yet we still this technology is here. It's coming. We have to adopt it, or we're going to be left behind in the long run. At the same time, if we don't properly educate the individuals that are going to be using it, we're not going to have the appropriate use of it. And I've seen this be successful and fail in two different ways. I've seen the education piece be approached from, look at what this can do, look at how it functions, look at how accurate it is, or it doesn't resonate. The reality is the clinicians need to understand what this does. Again, what does this do for me? How does this change my world? So and so over in the nursing arena, they did this. This is what their life looked like, and all of a sudden they get excited and they say, well, I want that. So there's a real piece of this that we need to start telling the story of how life looks with the technology in order to make sure people are educated on what it can do, what it can't do, how it's safe, how it's not safe.
Yeah, great point. So, what I heard is, look for solution for an existing problem and don't go around with the hammer looking for a nail. And looking for compliance, regulation changes, including changes in PAA and HIPAA. And having human in the loop is a good idea, especially with this. Like my take on AI is there is some parts that are just not explainable. Like the neural network itself. It is not reasoning based logic. It is like you ask the guy who's designed the neural network, and he'll not. The output which it produces for the same input is not. You understand? And you can't explain why it is not happening, right? So the reasoning part of AI has to be built into the model. That's the point I take on it. So great point. So we'll come to the final question, the winning question. So here, let's fast forward to end of 2026. If you had a, if you had to place a bet now on this year's trend, what data management technology or process you think will actually win by end of this year? Not just becoming popular, but what something which delivers value and control. Anyone wants to place a bet on any particular aspect?
Why not? Get your data sets clean. Getting data sets good and clean. I mentioned AI is here. It's not coming. It's here. There's going to come an inflection point when we have to accelerate the use. If you're not ready for that, the train will have already left the station. So I'm going to say by end of 2026, whatever you can do to have your data ready and have a true strategy around AI and the go forward plan that's what's going to win.
I'm going to be a little bit against that. I'm going to say late adopter is not a bad thing. Seeing what other people do or other organizations do and then following suit, it's not a bad thing. And I think the risk of this new technology, unproven technology, until it is proven, it carries a risk with it that's sometimes not beneficial. And I've read case articles by organizations implementing AI as we speak and helping them do this, helping them do that. But all these cases don't include all the effort and everything that was put into it. And if I see a large facility, let's say Mount Sinai or NYU or Montefiore, and they have implemented this AI system and they say this is proven to be a good solution for rehab or a good solution for PT, OT, whatever, I'll come to my users and I'll say, I've seen this and their IT director vouches for this solution and let's try it out as well. No shame in being a late adopter, in my opinion. And we're running a nursing home, so we're old.
Very good point. So this was a great discussion. Thank you very much for participating. So what I heard today is a lot about data control. It's about not just having one true source of truth, and not having just one vendor software guide all the solutions. It's about clarity in ownership of the data, clarity on access, clarity in purpose on how we use the data. So it all comes to not just the technology, but how you put the technology to use. So these are great inputs. Thank you so much for participating today. And I'll go over to join online. Thank you for participating and discussing this. Thank you.